Hello, I'm Randy Kearns with the University of New Orleans. This presentation is regarding pandemic preparedness, both looking at the local experience and the global experience during the most recent and other related pandemic events. The presentation was originally done for the World Affairs Council of New Orleans, and the purpose of the re-record is to distribute with their organization, as well as to use the content for other classes. So here at the University of New Orleans, I'm the program director for the healthcare management program. I also teach disaster management. I also have a gratis appointment at LSU Health Science Center here in New Orleans as an associate professor of research. And then I'm a retired clinical assistant professor from the School of Medicine at the University of North Carolina at Chapel Hill. Just a little bit about my background. I've historically worked as a paramedic, firefighter, rescue chief. I was the director of an EMS agency and an emergency management agency. And I used to teach people how to become paramedics at various community colleges when I worked in North Carolina. I've also worked in state and local emergency management, including the Federal Emergency Management Agency. I've been deployed to more than 30 now presidentially declared disasters. A couple of more notable events: incident commander for a field hospital at Waveland, Mississippi after Hurricane Katrina, and for a field hospital we established during President Obama's nomination acceptance in Charlotte. I've also worked as a special government employee for the FDA Medical Countermeasures Division. And although we didn't build out the field hospital, the second or third field hospitals that we at least planned to during the COVID-19 pandemic here in New Orleans, I've been identified as the incident commander for the second field hospital. I'm also an instructor for the UN Office of Counterterrorism, working as a contractor for the U.S. State Department, and we teach representative and partner countries. So things I am, things I'm not. I am an academic. I'm a researcher, and as such, read, distill information, put it into meaningful presentation so that we can share the information, and also that we can use the information to help us develop additional planning guides and other pieces of literature that's available in the scientific world. I do have a couple of rankings in something called ExpertScape, but it's important to note that I'm not a virologist, I'm not an epidemiologist, I'm not an infectious disease expert. I'm not a clinician. I once worked as a paramedic for a number of years, but my focus today is the academics, what type of research we can do and what we can learn from that research. So I will look at words, in particular, those that relate to this presentation, because words are important. They help us frame what we're talking about and better explain key topics that we want to discuss today. Infectious or communicable disease, zoonosis or zoonotic disease. When does an outbreak become a pandemic? And it's also important to point out that not all outbreaks go through that full cycle of outbreak, epidemic, pandemic, and then endemic. And we'll talk a little bit about that. And then 4 microorganisms that can make us humans, that can make us sick, and what's distinctly important about those 4. So we use infectious disease in a little bit broader terms. Infectious disease, we talk about it spreading from human to human, but when we talk about how an infectious disease spreads from human to human, we're more likely to describe that as a communicable disease. Again, both are somewhat interchangeable, but we're more likely to describe a communicable disease as something that can spread easily from one human to another. So with zoonotic disease, also referred to as zoonosis, we're talking about infectious disease where an animal host is able to infect a human, and the disease is able to move from an animal host to a human host. And And why that's important is there are literally thousands of diseases that are endemic in different animal species, but are not found in humans. And that's important as we talk about how disease spreads. And for that matter, if we talk about the origins of COVID-19, we'll get to that in just a minute. So as I mentioned, there are thousands and tens of thousands of viruses that exist in the world that are common within certain animal hosts, but typically do not spread from one animal to sometimes to another animal, and certainly from animal to human. Humans have a very robust autoimmune system, and we're able to protect ourselves in most cases. But where zoonosis occurs is when a virus is able to move from an animal host to a human. We'll discuss that a little bit more in just a minute, but it's important to note that viruses in general are much smaller than bacteria. Bacteria are single cell organisms. Viruses don't have a nuclei. They don't have cytoplasm or organelles, and they need a suitable environment for them to be able to replicate themselves, typically within the nucleus of the host cell. And to be able to do that, the viral genome must be able to enter the host cell. Again, we'll talk a little bit more about that, at least the parts that's important for the conversation today. As I mentioned, there are, again, literally thousands of viruses that we're aware of that have a great deal of difficulty moving across multiple hurdles to be able to move from a animal to human to human. And when we talk about this interspecies transfer zoonosis, that first hurdle is if humans are in close contact with a particular animal that's at maybe the peak of their infectious cycle, a human may be more susceptible to contracting that virus or that disease. But the second hurdle, which is vitally important, is if that infected human then infects another human from that disease that first came from an animal. Again, in most cases, we see diseases moving throughout the animal kingdom that does not include transfer to a human host. It's rare that it does. When it does, we call that zoonosis. It's also important to note that there are times that we've seen the transition from animal to human, but not human to human. And I'll give you a particular example shortly, but highly pathogenic avian influenza, H5N1, is one of those particular diseases that concerned us several years ago, doesn't concern us as much now, but certainly continues to be a disease of interest. So the four microorganisms that can make humans sick, a virus, a bacterium, a parasite, and a fungus. The plural version of that, viruses, bacteria, parasites, and fungi or fungi. I've heard it pronounced both ways, but just to note that the two that we're primarily going to focus on are viruses and bacteria. And for the sake of our greatest concern in terms of microorganisms that have caused the greatest number of pandemics in history, again, are either the nature of its viral in nature or bacteria in nature. And so with a virus, again, tiny microorganism diseases that we typically associate with a virus, coronavirus, adenovirus, influenza, measles, mumps, rabies, hepatitis. It's important to note that we don't have a lot of effective antiviral medications. Our best approach in dealing with a virus is developing a vaccine. Again, we'll talk more about that later on, but we don't, our best approach to dealing with some type of a viral outbreak is to treat the symptoms. We're not as effective, at least as a body of medicine, we're not as effective in being able to effectively treat patients with a virus. We manage the symptoms, which hopefully puts the patient's body in a better place to let the autoimmune system kick in and hopefully recover from the disease. I'll talk about coronavirus shortly. Just to understand that there are multiple different versions or strains of coronavirus. When we historically have gotten sick from a coronavirus, we've referred to it as a common head cold. Adenovirus produces very similar symptoms. Influenza, you know more about. And again, there are a number of varieties of influenza. We'll discuss that later on. Measles, mumps, hepatitis, those diseases are pretty much eradicated because of an effective vaccine program. Where we still see some of those cases pop up, it's when people have not been vaccinated. So the other microorganism is bacteria or bacterium, and this is a single cell organism. We've historically, now there was a time that let's look at one particular bacterium, pulmonary tuberculosis, TB, also known as Pott's disease, sometimes referred to as consumption, sometimes referred to as the White Plague. Just to understand that between the beginning of time, in terms of humans being on the planet, and about 1920, 12% or 1 in every 8 human beings died of TB. TB was really profound at different periods in our history. Even in the 1920s and the 1930s, here in America, we built very large hospitals just for taking care of large numbers of patients who had developed chronic conditions associated with TB. I used to live in a community where at one point there was a hospital there that had more than 4,000, 5,000 patients with TB within that hospital. And so what has changed, and changed in a really dramatic way, is our development of antibiotics. Antibiotics allow us to dramatically reduce the spread of a bacterial disease and effectively treat patients with a bacterial disease, and in most cases be able to cure patients with a bacterial disease. So between 1334 and 1353, probably the most substantial pandemic that ever occurred on the planet occurred during that period. It was linked to a particular bacterium known as Yersinia pestis, more commonly referred to as the plague. Also, that period was known as the Black Death, and that's in part because of what we see from the patient when they're infected with Yersinia pestis. The main point here is it was transmitted human to human. At one point, we thought it was probably transmitted by rats, but more recently, we've come to realize that probably the vector transferring the disease was one human to another human. Tens of millions died in China, southern Mongolia, northern India in the 1330s and 1340s. We have more complete records from Europe, and we know that there was a substantial outbreak that began there about 1347 and ended between 1351 and 1353. But by 1353, it's estimated that about 60% of the entire population of Europe had died from the plague. Although we do include parasites, and in just a minute, fungi or fungi. It's also important to note that the vector of the transmission of the disease caused by parasites is a lot more problematic. It's a little bit easier to protect yourself, and it's a little bit easier for us to be able to manage parasitic type diseases. And just to quickly say something about fungi, or also pronounced fungi, for the most part, just like parasitic diseases, we have reasonably good ways of treating patients with a fungal infection, and it's far less likely to cause any type of a substantial outbreak, much less anything else that we would tie to a pandemic event. So that kind of takes us back to our topic sentence, so to speak. Our primary threats are viruses and bacteria. Viruses pose the greatest threat. Bacteria pose a reasonable threat, but it's difficult to have the rapid transmission today, primarily because of our hygiene. Traits have changed pretty dramatically over the last several hundred years, and to a much lesser extent, parasitic diseases or fungal diseases. And then this is just a good overview comparing the differences between viruses and bacteria. So earlier I mentioned stages. When we talk about stages of disease, outbreak, epidemic, pandemic, and endemic, not every disease will go through all four stages. In fact, it's normal for us to have an outbreak of some type of communicable disease every year in some part of the country. It's an unusual case count of patients generally with some type of a virus, either an adenovirus or a coronavirus. And the whole point to this is we pay attention to those cases. We may try and move some additional resources into a community, but we're monitoring it just to be sure that we don't have something unusual going on. If it's epidemic, it's considered more widespread. Again, it may be in a particular community for a particular time. And if it becomes more global and is a novel virus that moves into what we consider a pandemic, I'll talk a little bit more about that in just a minute. Most diseases that we deal with today in the human population we consider endemic. And what I mean by that is it's a common disease that's commonly found in our community. Every year, certain types of head colds that we may associate with a coronavirus or an adenovirus, certain influenzas circulate through the community. People who either have a robust autoimmune system are less likely to be affected by it. People who have been vaccinated are certainly less likely to be affected by it. But most of our common diseases we consider endemic in nature. So let's specifically for a moment focus on what a pandemic is. And let's use a virus as an example. A new viral subtype emerges, and that's what occurred with SARS coronavirus 2, more commonly known today as COVID-19. There's no or little human immunity. It infects humans and causes illness, and is easily spread without much interruption from person to person. Those three things are key for it to be defined as a pandemic. And in just a minute, I'll talk a little bit more about other pandemic events that have occurred historically and what that has meant for us in terms of what we understand about pandemic events. One other thing you may hear, particularly you heard a lot during COVID-19, if you were paying attention to the scientific community, they may talk about the R0 value. The R0 value is a calculated, it helps us understand what the spreadability is of an infectious disease. And it considers three factors. The infectious period, how long does it take from the time someone is infected until the time that they are contagious. Mode of transmission, is it airborne? Is it when we dealt with Ebola several years ago, and to some extent some parts of the world are still dealing with Ebola, but the method of transmission for Ebola is blood or body fluid exchange. And so that really limits the number of people that can be exposed to the virus. It's very deadly and very dangerous, but because the mode of transmission is quite limited, the R naught value of it is actually quite low. And then contact rate. Um, what's the chances that we're going to spread this from one person to another? Again, those three factors feed into a calculation known as R naught. The larger the number, the more concern we have for spreadability of a particular disease. Dr. Joshua Lederberg earned a Nobel laureate in 1958, or was awarded a Nobel laureate in 1958 in physiology and medicine. And this quote is attributed to him: the single biggest threat to man's continued dominance on the planet is the virus. And I think it's really important for us to remember that parasitic infections, fungal infections, we generally can manage them well. Bacterial infections still challenge us some, but we have a lot of effective means of treating bacterial infections. Viral infections, we don't. Our best method of managing viral infection is a vaccine. And again, we'll talk a little bit more about that in just a minute. So when we talk about critical pandemic events that have occurred in our history, three immediately come to mind, and that is the Black Death or the Black Plague of the 1330s through 1350. Again, it was more profound in Europe between 1347 and 1351. It was pretty much considered over by 1353. But if we look at Asia, particularly China, Mongolia, India, we see tens of millions that were killed in this pandemic event between 1334 and the late 1340s. So really a profound event. More recently, about 105 years ago, was the 1918 influenza pandemic. Again, killed a substantial part of the world population. That was a unique version of H1N1 influenza, and I'll talk a little bit more about that in a minute. And then more recently, the COVID-19 virus, scientifically is known as SARS coronavirus 2. Again, we'll discuss that a little bit more in a minute, but somewhere between 0.3 to 2% of the world population has died from COVID-19. So as I mentioned, again, probably the deadliest pandemic in the history of the planet was the Black Plague or the Black Death of 1334 to 1353. And physicians or doctors that took care of patients in that period actually had personal protective equipment somewhat similar, at least in theory, to what physicians would wear today. Something to protect the head, something to protect the eyes, a shroud around the face. In this particular case, the plague doctor is wearing a large flowing coat, but a gown a doctor would wear today with scrubs. Gloves, again, all of the things that you would kind of think of, not necessarily looking the same way. Probably the one really unique thing is this long extended beak. Just understand that long extended beak that the plague doctor wore, 800 years ago, had crushed dried flowers in that beak area to help filter out some of the odors. And you can imagine how difficult it may have been to care for patients with those open sores and some of the other things that you can imagine you would associate with widespread death and lots of dying and sick people. One thing that I did want to point out is this wand to direct the patient. The voice may be difficult to hear. There's an old phrase or euphemism known as "I wouldn't touch that with a 10-foot stick." This is actually the origin of that. It's at least believed to be the origin of that, and how the plague doctor in those days would use a stick to poke a patient to hopefully arouse them, and to use a stick to direct them in how to do certain things. So this particular picture comes from a field hospital here in the United States during the 1918 influenza pandemic. And while at first glance it looks like they put a whole lot of people in a very small space, the reality is there's some deliberate view in what they're doing. They're putting the head of one patient at the foot of another patient, the head of that patient's at the foot of another patient. And although the angle of the picture kind of leads you to believe that they're pretty close together, they're actually not. Um, Three things that we've done with new and novel diseases for more than 100 years now includes the focus on hygiene, washing our hands, distance, trying to maintain a certain distance between you and someone else who may be infected, to reduce the potential for spread or transmission, and then wearing a mask when you're close to other people, either if you're sick or if you're not sick, trying to protect yourself. But again, those three things were published in an article, I think about 1907, and have been common themes that we use in public health until we can develop more effective treatments and hopefully a cure and certainly a vaccine for these types of diseases. So I've told you a lot about the Black Death or the Black Plague of the 14th century. Let's talk a little bit about the 20th century, what's known as the Spanish flu. It's a novel H1N1 influenza strain. I'll talk a little bit more about H1N1 in just a minute. The thing that was unusual about it was there was a disproportionate number of victims who were under 18 years of age. We saw a little bit of that in the 2009 influenza pandemic. We just didn't have anywhere near the mortality rate. But anytime, it's one thing for a lot of people to get sick. It's another thing for there to be an unusual mortality rate for people who are very young. It's believed they have a really robust autoimmune system, but it somehow doesn't work real well under certain circumstances, particularly when seeing a new novel virus. And that's what occurred with the 1918 influenza pandemic. Please understand, though, in 1918, the influenza, while is most commonly referred to as the Spanish flu, that's because much of the world was involved in World War I. In Spain, they weren't as involved in World War I, and local reporters had more freedom to report on people who were getting sick with this unusual influenza. Just understand the death toll, the mortality rate, morbidity rate was about the same thing in Spain as it was in America as it was in much of Europe. The difference was there was a lot of concern and there was a little bit more press control during the war in 1918 than there would be today. And so it was believed that bad news would undermine troop morale. And so there was a lot less written about it in the American press and in much of the European press than it was in the Spanish press. And so we commonly referred to it as the Spanish flu. The reality was it was just as fatal and just as deadly there as it was in the rest of Europe and the rest of America, for that matter. So there have been four pandemic events over the last 125 years. All four of them have been tied to an influenza, talking about before the most recent pandemic associated with COVID-19. And those were associated with some type of influenza virus subtype. I'll go over virus subtypes in just a minute. Historically, they've been commonly referred to as the Spanish flu, the Asian flu, the Hong Kong flu, and the swine flu. Just understand that in many cases, or actually in all four of those cases, that type of nomenclature is misleading at best and can be dangerous at its worst. So a naming structure has been put into place that's included in your slide, and we'll talk a little bit more about specifically virus types and virus subtypes in just a minute. So there are four types of influenza viruses, type A, type B, type C, and type D. A and B are primarily associated with seasonal influenza, can be epidemic at times. Certainly we associate it with different outbreaks that may occur from community to community. Um, Virus A, influenza A, is the only virus that we've so far associated with a flu pandemic or an influenza pandemic. Influenza C can cause some mild symptoms, and influenza D has not been seen in humans, at least at this time. So if we break it down a little bit more into influenza A and influenza B, and the reason that I've highlighted this on your slide is if you take an influenza vaccine, your influenza vaccine represents two types and two subtypes of each of those types. So there's four different components within the influenza vaccine today. It addresses subtype A, which is H1N1, subtype A, H3N2, and then from influenza B, the lineage of Victoria and the lineage of Yamagata. And so it's not so important to know that. It's just important to understand that when you take your flu vaccine each year, and hopefully you do take your flu vaccine each year, the CDC and the World Health Organization get together to try and predict what's going to be the greatest threat. And usually they land on something similar to these two subtypes and these two lineages of influenza B. So let's specifically look at influenza A just a moment. We subdivide influenza A based on two proteins on the surface of the virus. The hemagglutinin, referred to as H, and the neuraminidase, referred to as N. There are 18 different versions of hemagglutinin, 11 different versions of neuraminidase. A vast majority of those different subtypes are found in avian host and other types of animal host, but not in the human population. From a disaster planning standpoint, one of the critical times that we've been involved in the public health world in terms of disaster planning for a pandemic that honestly never happened was the concern of what was commonly referred to as bird flu, H5N1. H5N1 has a very high mortality rate. It spreads quickly in the animal kingdom and moves quickly from typically one chicken to another. There have been literally tens of millions and hundreds of millions of birds killed at one time or another because of an outbreak of H5N1. But it's been rare that the disease was transmitted from the bird flock to typically a human caregiver of that flock. And has been incredibly rare that it was transferred from human to human, typically within the same family unit. But just understand that H5N1 has a very high mortality rate. And in 2003, we were concerned that the next pandemic was on the horizon and it was going to include H5N1. And if the R naught factor was going to be high, we were going to have a lot of illness and a lot of death associated with it. Didn't turn out that way, but that was one of those great pandemic threats that we were concerned about. H5N1 is also commonly referred to as HPAI, highly pathogenic avian influenza. Again, it occurs primarily in birds, most commonly found in domestic poultry. But by 2003, again, we saw substantial outbreaks of this disease, and bird population, it just for whatever reason never made that zoonotic jump to humans in a way that the disease was easily spread from human to human. We've just never gotten to that point. There are cases that still continue to show up from time to time of H5N1 that still has a high mortality rate, but the number of cases that we see of the spread from a flock of birds or a particular infected bird to a human, those numbers are small, and continue to be small, which is really a good thing. So when we talk about mutation and interspecies transfer, earlier I talked about hurdles. What are the hurdles that it takes in zoonosis for a virus to move from an animal host to a human? Humans have a robust autoimmune system. We hopefully have pretty good hygiene standards, and so there are a lot of things that we do that we protect ourselves from an interspecies transfer of these diseases. But when something does occur, in 2009, we saw an H1N1 strain, a subtype of H1N1 that had some genetic contribution from an avian reservoir and some genetic contribution from a pig reservoir. And it was commonly referred to as swine flu. But more than anything else, we again saw unusual patterns of an outbreak, no known immunity. It was spreading quickly. And in 2009, it was classified as a pandemic. Now, it didn't have anywhere near the case fatality rate. I mean, there were still people who lost their lives, but the numbers were much smaller than what we saw with previous H1N1 or other types of influenza pandemics. Okay, so we've talked a lot about influenza. Let's spend just a couple of minutes talking about coronaviruses in general. We've known about coronaviruses for more than 50 years. There are 7 different members of the coronavirus family today that we know of that exist that can spread from human to human. Most of the time when someone is infected with a coronavirus, it produces symptoms that we commonly refer to as a cold. He has a head cold. Just understand that under an electron microscope, coronavirus has a certain appearance that gives it that crown type look, and thus the name of a coronavirus. So of the 7 human coronaviruses that we know can infect one human to another, there are 3 that we've seen over the last 20 years with particularly deadly consequences. The other 4 we commonly associate with a head cold. But the 3 that we've seen higher mortality rates included the first time we saw SARS coronavirus, 2003. SARS is severe acute respiratory syndrome. It was not until several years later that we did confirm that it was a coronavirus, but we realized that, so when you hear the word syndrome, what that means is there's a number of conditions that are very similar that are making people sick that we believe is tied to one particular type of either virus or bacteria, most likely a virus. We use the word syndrome because we're not sure at that point. Later on, when we are sure, we may keep that within the name of it, but that's how it moved. That's how its name evolved to SARS coronavirus, and today known as SARS coronavirus 1. A Middle Eastern variety strain of this emerged in 2012, also had a high case fatality rate. We commonly refer to that as MERS coronavirus. And then when this appeared, when COVID-19 first appeared, late 2019, early 2020, we weren't sure if the original SARS was back with us genomically. Once we were able to map it, we realized it was different enough from the original SARS coronavirus that it was, and today in scientific literature is referred to as SARS coronavirus 2. The more common name that was given to it by the World Health Organization was COVID-19. And that's based on COVID for coronavirus ID, meaning we ID this as a coronavirus, and it was identified in 2019. So that's how they came up with the name COVID-19. So let's take just a moment to talk about the original SARS. The first documented case of SARS occurred in the early 1990s. First documented mainland China, transmitted by aerosolized droplets. So again, sneezing, coughing, these very microscopically very small virus particles can move from person to person, again, based on a sneeze or a cough. Produced a pneumonia-like disease. The 2002 to 2003 outbreak infected almost 10,000 people, killed nearly 1,000 people. It was eventually confirmed as a coronavirus and thus changed in the literature to reflect SARS coronavirus, and again today referred to as SARS-CoV-1. The pathogenesis, probably the main point I would make here is the first person to identify this syndrome treated someone with flu-like symptoms, but he was able to isolate it and identify that the virus was not an influenza virus, but was in fact something else. He identified its uniqueness, reported it to the World Health Organization, and Dr. Urbani is credited with discovering the disease. Sadly, it took his life just a few weeks later. So by the time the disease spread to other parts of the world, including some Canadians traveling from Hong Kong, believed to have been the vectors. Again, some of the deaths there included nurses and physicians who were treating patients with SARS. And just to kind of put this in perspective, at that particular time, I lived in North Carolina. We had one person who had traveled from Canada back to the Raleigh-Durham area. That one person began displaying symptoms that the concern was this particular person may have had SARS. The bigger problem was this person had worked as a waiter at an area restaurant that was a pretty popular restaurant. And so out of an abundance of caution, public health said, basically, if you've had a meal at this particular restaurant on these particular days, it may be a good idea to consult a medical professional. To put things in perspective, so this is the hospital system I used to work at. There's 5 hospitals that are lined up side by side. They're all connected together. That's called the University of North Carolina Hospital System. And these 5 hospitals have obviously a lot of resources. They set up a large tent area. We, the University Medical Center, saw over 600 patients who were concerned that they may have been exposed to this particular disease. As it turned out, no one tested positive for SARS, but more than 600 people self-evacuated, came to the hospital, wanted to be tested. We classified them as the worried well. But that's the bigger challenge that we have early into any of these types of pandemic events, is trying to keep the messaging under control and to answer questions as accurately as we can and concisely as we can, and provide treatment anywhere that someone has symptoms that tell us that they may be sick. MERS coronavirus, we still see cases of this, but it's obviously not as contagious. It is similar to SARS. It's deadlier than SARS. Again, depending on what type of access to care people have. If people have access to care that's good, high quality care, the mortality rate is still about 10%. If they have poor access to good quality care, the mortality rate is about 67%. About 2 out of 3 people will die from the disease. The one advantage to it is, again, it does not spread rapidly, and so we've not seen a lot of cases over the last several years. I do have another slide about MERS, but nothing more here to discuss that we haven't already talked about. So let's talk about SARS-CoV-2, otherwise known as COVID-19. So the first public announcement of this was the 31st of December 2019 as a novel respiratory illness, again classified early on, or at least initially identified as a severe acute respiratory syndrome, SARS. Once they were able to genomically map the virus, they understood that this was a different strain than what had historically been mapped as SARS-CoV-1, and thus this became SARS-CoV-2. Again, it's still officially referred to in scientific literature as SARS coronavirus 2, but the more common nomenclature used is COVID-19. The pathogenesis, again, somewhat similar to the original SARS. I won't get into a lot of details. The main thing I'll point out here is early on when we see these types of unique viruses that we're not sure about, treating symptoms is the best approach. In other words, early on we saw patients developing blood clots, so we would use anticoagulants. They had trouble breathing, so we gave them oxygen. If we're trying to help them breathe, we may use a corticosteroid. Steroids help open up airway passages. Now we use an antiviral, Paxlovid. And then obviously we try to avoid the disease with vaccines. But Li Wenliang is the Chinese physician who probably identified this first. He messaged several doctors on the 30th of December saying he had seen several patients with an unusual type of disease, and it seemed to be spreading quickly. Early on, he was reprimanded for what was considered making false statements. Sadly, he became sick also with the disease, and in early February of 2020 died of the disease. To kind of bring this back home here to New Orleans just a minute, you know, it was believed that Mardi Gras may have been kind of that again, in retrospect, at the time, we knew it was out there. We didn't know it was here. We certainly didn't know it was in New Orleans. And, you know, having talked to a number of public health officials, you know, hindsight's always 20/20. As soon as we had confirmation that there were cases, several cases, the decision was made to shut down the town. And actually, this is a picture of police vehicles moving through the French Quarter on St. Patrick's Day evening, which is obviously a big evening in the French Quarter and in all of New Orleans. But the point was, we realized this was getting out of control and getting out of control quickly. Our not estimation was putting some really ugly numbers in what we could possibly be seeing, to the point that one of these headlines included the potential collapse of certain aspects of our hospital system. And that's why we were rapidly identifying places that we could create emergency hospitals if we needed to stand up and create that type of additional resource to help support the hospital system here in New Orleans. So this is kind of a busy slide, but and when we talk about we want to flatten the curve, what we mean by flattening the curve is if a lot of people are sick at one time, they consume a lot of resources. It also makes it very easy for the disease to rapidly spread. If we can flatten the curve, it allows us to more evenly and accurately distribute the resources and to provide an adequate amount of care to everyone who is sick. The more you have peaks in a disease outbreak of any type of disease, the more difficult it is to care for, particularly the sickest patients during the peak of the disease. This is an overlay of Asia, Africa, Europe, North America, and South America. And probably the one piece you'll notice, the Asia data doesn't really spike until about May of 2021, and that's when the disease struck India with a vengeance. Now, this is only as accurate as the country reporting the data, and so we're not completely confident that all the countries around the world reported the data the same way and with the same accuracy. So it's a little bit difficult, but these are at least the confirmed numbers that have been reported, and does give us an idea of kind of some contrast of how the disease was moving around the planet. So let's talk about public health just a minute. Our definition of public health: science and art of preventing disease, prolonging life, and promoting health. And the whole aim to this is to be sure that we understand the role public health has in any disaster planning, disaster operation, particularly disasters as they relate to people who develop some type of an illness or some type of disease. When we're talking about the core sciences of public health, we're talking about epidemiology, surveillance, informatics, laboratory sciences, and prevention. In just a minute, I'll go through each of these. With epidemiology, we're looking at signs and symptoms of what has made someone sick. We're trying to look at the disease process. We're trying to sort out isolation strategies and quarantine strategies. And when you hear those two words, understand they have different meanings. When we talk about isolation, think illness, someone is sick. If we're isolating someone, we're isolating someone who is sick. Illness, isolation. Quarantine is when someone has been exposed but are not showing signs and symptoms. And so when we talk about quarantining people, they're at risk for the disease, but they're not showing signs and symptoms of illness. So illness, isolation, quarantine, someone who's been exposed. And one last thing about epidemiology is trying to understand the method of transmission. Is it airborne? Is it transmitted through aerosolized particles or blood or body fluids, such as we saw with Ebola? There's something else that we do early into an infectious disease, and that's tracking those who are exposed or potentially infected. That's called contact tracing. Contact tracing works really well with certain types of diseases. With Ebola, as an example, contact tracing helped us really nail down people who were at risk and actually in some cases later developed symptoms. And then people who we needed to quarantine who in some cases didn't develop symptoms but had been exposed. Contact tracing failed miserably as we were trying to apply it to COVID-19. We didn't know, and so because contact tracing is a common way that we look at things in the disease outbreak process, it did make sense early on, but it was also something that we abandoned fairly quickly into the process as we began to realize it just wasn't going to be effective. So what we mean by surveillance, each hospital reports unusual types of and actually common types of infectious disease, new types of trends, and those data are reported to state public health, not just here in Louisiana, but in every state. And the whole purpose to that is so that state public health can monitor if there's an unusual trend developing in a certain community. It may tell us that an outbreak of a given disease may be starting in a given community. If we know that, we can move resources into that community, we can alert the public, we can alert providers in that area of what to be on the look out for. And so the whole point to surveillance is kind of an early warning system of when a new or unusual disease trend may begin to occur or emerge. So informatics is about leveraging computer technology, data scientists, the types of information that we're going to get from laboratory services and from surveillance, and doing that in a way to help us quickly and accurately analyze what's going on. The quicker we can alert a community to a potential disease outbreak, or if maybe there was a food poisoning event at a given location, informatics is kind of the basis for that. It's the backbone of tying all of those pieces together. It's very important for us to analyze the data quickly and be able to distill that into something that we can message to the general public, particularly when the public needs to be alerted to what's going on. The laboratory science side of this is essential in any public health agency. The largest laboratory system for communicable disease is in Atlanta, the Centers for Disease Control and Prevention. Each state has a state lab. The whole point to a lab is to have some regional testing capability, just to understand that when a new and unusual disease emerges, it may take days, weeks, in some cases months to develop an effective test so that we can understand the nature of the disease quite quickly. Now, we were fortunate in the fact that we were able to genomically map the virus very quickly and within a couple of months develop a very effective testing procedure. Just understand that about 90% of all of the testing infrastructure that we needed to set up for COVID-19 did not exist before COVID-19 occurred. So not only are we trying to design a test, we're also trying to design a number of regional testing labs to be able to rapidly test these samples. And then later developing home testing kits so that we didn't have so much reliance on that type of medical infrastructure. You know, prevention has always been the cornerstone of public health, and prevention strategies that we use today are some of the same prevention strategies that we used, 100 years ago. In some cases were identified in the literature 110, 115 years ago. And that is, how do we reduce the transmission? If we think about ways that we transmit disease through touch. And so physically distancing ourselves from someone else that may have the disease, ways that we may pass the disease through things that we touch that they may touch, coughing or sneezing, being able to cover a cough or a sneeze, either with a mask or protecting yourself with a mask. But again, masking strategies, physical distance, hygiene, all of those approaches have been common approaches to managing communicable disease transmission for the last 100 years. It generally worked during COVID-19. It worked reasonably well. Just understand there's no absolute science to any of this. Early on, I think we were giving instructions of you want to maintain 3-foot distance, and then later we said 6 foot in distance. Just there's diminishing returns for the greater the distance, but the whole point is if you understand that anyone around you may potentially be sick, creating some space between you and them is only reasonable in trying to cut down the transmission. And that's the whole aim behind prevention, is trying to cut down the spread of the disease. Because again, back to that flattening the curve approach. probably the only thing I'll say about this slide is it's essential that we understand the method of transmission. The more we understand the method of transmission, the more we can focus on how the disease is spread and then how to reduce the spread of the disease. So in the early days of any new disease outbreak, we're going to focus on the things that are simple and the things that we've historically done. Hygiene, contact surface cleaning, antibacterial or antifungal sprays and cleaners, disinfectants. Physical distance, maintaining a certain physical distance. If someone is sick, isolating them. If someone has been exposed but not showing signs and symptoms, quarantining them. And then masking, both to, if you're sick, prevent the spread through aerosolization, and if they're sick, to try and capture the virus before you inhale it, and hopefully not inhale it, capture it on the outside of your mask. And then long-term treatments and vaccines. Just understand that any new disease that arises, we typically won't have a treatment for it. Particularly if it's a virus, we don't have a lot of effective antiviral medications. And then developing an effective vaccine. Again, we were lucky in the fact that we were able to quickly develop the genomic map of the virus so that we understood how it was structured and could develop a way to create an effective vaccine for it. But just understand some viruses we've not been nearly as successful. HIV as an example, the human immunodeficiency virus has been around for more than 40 years and we've still not developed an effective vaccine for it. Fortunately, it doesn't spread the same way COVID-19 does, but just understand that the fact that we were able to quickly develop a vaccine within about a year from the time the disease first appeared until the time we were ready to roll out a vaccine for the majority of the population was really dramatic. It's a testament to how much science was able to effectively work together around the globe to come up with effective solutions. So when we talk about immediate actions, educating the public, being sure that the public has all of the information that you have from the scientific community. You know, in the absence of information, sometimes people make it up, and that's some of the things that we saw. We saw a lot of really nonsensical information being spread, particularly on social media, which was really unhelpful and continues to be unhelpful for that matter. But being sure that the public has all of the information that you have, and the whole aim is to stop the spread of the disease. What are the ways that we can slow down the spread of the disease? And I'm talking about the cleaning that we can do, the distancing that we can maintain, certain hygiene, being sure that we focus on it, wearing a mask when you're in close proximity to other people, and then maintaining a certain distance where you can. Identify those who are sick and isolate them, identify those who have been exposed and quarantine them, enhance hospital capacity. You know, you saw, again, when we talk about flattening the curve, that large curve, that large peak of patients surging into the hospital really ate up a lot of hospital capacity in the early days. We ran out of beds, and that was a part of building that mobile field or that field hospital in the convention center. We actually had plans to develop 2 more if we needed them. Develop mass testing. The sooner we know who is sick, the better off we're going to be in terms of helping them deal with the disease. And then develop best practice. Early on, we had a much higher case fatality rate around the world, but we had a higher case fatality rate here in America because we'd never seen the disease before. Once we had some experience with the disease, once we understood what types of what different cycles the patient would go through, we were able to develop best practice. and dramatically reduce the mortality rate. But some of the people early on who contracted the disease, would have lived today had they contracted the disease today. But because, again, we're dealing with a novel disease, we don't know exactly what's the best practice at that time. And then developing a vaccine and then offer mass vaccination. The sooner you can develop a vaccine, the sooner you can vaccinate. We have very few effective antiviral medications. Our best approach in dealing with a virus has been to develop a vaccine and continues to be to develop a vaccine. And that is certainly one of the challenges we face. When we talk about enhancing hospital capacity, I won't spend a lot of time on this, but we focus on something in the disaster world called surge capacity. How much staff do you have? How much space do you have? How many supplies do you have? And what type of system do you have in place? The whole aim to surge capacity is to decompress the disaster itself. And we either do that by bringing more responders, supplies that into the event, and then taking care of patients and getting them discharged from the hospital, so to speak. But once we reach that balance, referred to as surge equilibrium, but once we reach that balance, it's a lot easier to effectively take care of the patients. But the science continues to tell us that when we're overwhelmed as caregivers, we don't do a great job of taking care of all of the patients at one time. So the sooner we can get back to a reasonable ratio of clinician to caregiver to patient, the better off the patients are going to be. During the 1918 flu pandemic, we quickly ran out of hospital space, and we had to create these, what's known as a temporary emergency hospital. This one in particular is in a gymnasium, but churches were used, gymnasiums were used, schools were used, but it gave us a place that we could put the patients who were sick and put caregivers in those areas to be able to take care of those patients. And this temporary emergency hospital approach has been a solution that we've used then and continue to use now. By the middle 1950s, our concern at that time was not so much a pandemic, it was a nuclear war with the Soviet Union. And so a number of civil defense emergency hospitals were created. They were basically mobile hospitals. They were based on a military type approach. They were 200-bed hospitals. And to kind of put this in perspective of what we saw here in Louisiana. So around the U.S., there were just under 2,000 of these 200-bed disaster hospitals that were created. Here in Louisiana, 31 were assigned in various parts of the state. One was used for training, the other 30 were assigned. And the whole aim was to be sure that we had temporary hospital space if we did wind up going to war with the Soviet Union, and we did wind up with a large number of people having injuries, civilian population having injuries as a part of that war. So today, again, a number of states have operated, created, and used some type of a temporary hospital. This is a particular temporary hospital that I was a part of the operation that we set up in Waveland, Mississippi after Hurricane Katrina. We saw approximately 8,000 patients with another 8,000 people that came through for some type of a vaccine or prescription refill. But these temporary hospitals are ways that we can help decompress or relieve the stress on the healthcare system, at least on a temporary basis. And this is just a picture from our command staff meeting. We met daily to talk about, again, a planning strategy of it's a temporary hospital. We're only going to operate it for a short period of time. We were there for 8 weeks and closed it down and transferred that operation to, by that time, the Air Force had stood up a a hospital and working there with the local hospital to bring some of their staff back into it. But again, the idea was to transfer out the temporary hospital and move to more of a permanent type setting. And this is just another temporary hospital that I was one of the incident commanders for. We set it up. This actually would have seen 500 patients during President Obama's renomination process. The Democratic National Convention was held in Charlotte, so we set up and operated a temporary hospital. It was never needed, but if there was suddenly a mass casualty event that produced a significant number of injured patients that overwhelmed the local healthcare system, we had a temporary hospital that we created to be able to manage that. And so by 2020, this is what temporary hospitals looked like in the immediate days following the beginning of the COVID-19 pandemic. In Wuhan, China, they actually built concrete buildings, and they built them in about a month and a half. They built 2 1,000-bed hospitals in Wuhan, China. Having been to China a couple of times, it's pretty impressive how quickly they can construct something like that. But here in New Orleans, we already had a very large structure in place, and that was the convention center. And so within that convention center, we used temporary type shelters to set up basically a 12-foot by 12-foot patient room. But we had the capacity to be able to build this out to about 2,000 patients. I think we stopped at about 1,100, and I don't think we ever had more than about 200 patients in there. But the main thing is we knew if we wound up with not just hundreds but thousands of patients, that we had the capacity to be able to add on and to be able to accommodate those patients, at least on a temporary basis. And I was identified as the incident commander for one of the field hospitals. We wound up not having to build out hospital number 2 and hospital number 3. We did plan for it, but once again, back to the data, once we knew what the trends were, and once we saw the trends falling back to at least a more manageable level, we knew that we would not need to do that. And by that time, the local hospitals had time to expand into some space that was available to them. So the local hospitals had time to ramp up and really gave us a chance to start breaking our temporary hospitals. And the last of our temporary hospitals closed here in New Orleans by July of 2020. The next step in any type of a pandemic event, as quickly as a vaccine is available, and fortunately there were multiple types of vaccines that were developed around the world. Some were more effective than others, but to date, more than 13 billion doses of vaccine have been administered. Developing a mass vaccination process to globally vaccinate as much of the population as you can really was very effective in being able to cut down the spread of the disease and for all practical purposes dramatically reduce the case fatality rate and the morbidity associated with the disease. Just a couple of final thoughts about viruses and vaccines. Polio is a virus. If we look back to what polio looked like in the 1940s, this is what a polio unit looks like. If you look closely at this photo, you'll see literally dozens of people who have to live a majority of their life in this is called an iron lung. It's a metal cylinder that you place the patient in, and around the neck and around the feet, it's sealed off so that you can create a vacuum inside of that iron lung, and it helps pull the lungs open so that you can breathe. A majority of these patients, actually, I just saw a news blurb recently where someone who was still living in an iron lung just died in the last several days. Um, Understand that when you have a virus that has a great deal of morbidity, such as this, and in many cases can be fatal, a vaccine is an enormous advantage to be able to avoid something like this. This is what polio units look like before the vaccine, and so, and I realize this is just a stock image, but the whole reminder here is the medical community's not done a has had a lot of setbacks in trying to develop effective antiviral medications. They continue to work on it, but just the nature of a virus makes it very difficult to do. It's much easier and much more effective to develop a way to prevent the virus, and that prevention strategy is through a vaccine. Um, Polio was a highly contagious disease that caused a lot of death and a lot of disability before we had the vaccine. Now that we have the vaccine, there are very few cases of polio around the planet today, and that's a tribute to how the scientific community was able to develop an effective vaccine and put us in the place where we are today. So let's kind of recap COVID-19 specifically, and maybe the next viral pandemic in general. Early on, we've got to identify the epidemiology, what's going on with it, what type of best practices are there for how to care for these patients, and then distribute that information. Those treatment regimens are essential. The scientific community did a great job of working together to try and identify the virus and then develop structurally ways to attack and approach the virus, to prevent it with a vaccine and to treat it with, we've created Paxlovid, a very effective antiviral medication specifically for the disease. We've created a number of very effective vaccines to prevent the disease. Relying on mRNA technology was really essential in being able to develop this as quickly as they did. mRNA technology has been around for more than 30 years. We primarily use it to deliver more expensive types of medications because it's a fairly pricey delivery method. But because they created literally billions of doses, it was a much cheaper way to do it and a much more effective way to do it. The viral vector vaccine is a common way that we've been building vaccines for a number of years. Actually, early on, I was vaccinated with a viral vector vaccine. They're just not as effective short-term or long-term as an mRNA vaccine. The sad part about COVID-19, there were winners and losers. There were people who were able to work from home, and there were people who lost their entire livelihood because of the disease. And, the real challenge we're going to have is if the next pandemic event occurs sooner rather than later, it's going to be difficult to get people to comply with some of the things that we're going to need to do to, again, be effective. There were a lot of things that went very well during the COVID-19 response. There were a lot of things that did not go well. And as we, again, recap and review that, hopefully public health and on a grander level, the healthcare system in general has learned a lot from that. Other things I would say about the pandemic is, honestly, we were lucky. The case fatality rate could have easily been much higher. Early on was about 4%. Today is closer to about 1/10 of 1%. And so when we talk about case fatality rate being a lot lower today, just understand it's still deadlier than influenza H1N1. It's still there. We still need to be mindful of it. But again, the disease has become mostly endemic. It probably will be with us for the foreseeable future. The anti-vax beliefs that were prevalent in the Pacific Northwest, and I don't. We've got to sort the politics out of the science. The science will help us, but we have to be focused on what the science says. The challenge is we measure things in a binary way. Did it help me or did it not help me? Was I impacted? Was I not impacted? Do I have a friend, a neighbor, a colleague, a relative? And so it's far more difficult to convince everyone of the mission and the importance of infection control, isolation and quarantine procedures, masking compliance. And a mask isn't essential in a lot of environments, but when we're in close contact with other people, a mask is an important way an additional barrier to help reduce the spread of the disease. And so, again, the challenge that we're going to have in the future is there will be people who resist future advice just simply because of some of the experiences they had this time. So at the time this is recorded, a couple of months ago, February of this year, a panel of experts came together from the University of Nebraska, which is one of the major research centers in the United States looking at infectious and communicable disease. And they talked about what were the 8 future pandemics that they could foresee. One's another coronavirus, something that's a viral hemorrhagic fever, something from the family of viruses that give us measles and mumps, and influenza. And to be quite honest, before COVID-19, influenza was what we were constantly seeing as that next emerging threat, some novel strain of influenza. Valley fever, Zika, both are mosquito-borne vector viruses, and then Laissez fever, which is also a viral hemorrhagic fever. The viral hemorrhagic fevers are certainly concerning. Any of those are concerning. And there's something else that has been identified by the World Health Organization as disease X. And what that really means is we don't know what it is, but it should remind us to always be aware of that next outbreak. And does that outbreak, is that foretelling of what could be the next epidemic and potentially take us to the next pandemic? And then what causes these things? The easiest explanation is typically the correct explanation. And the simplest answer to any new emerging infectious disease is we typically trace to some type of spillover, something that's occurred in a zoonotic type effect. It came from a bat, as an example, is the most common belief for COVID-19. Could it be a lab leak? Could it be? There are a lot of things out there that, in theory, it could be. Until we know for sure, nothing has been eliminated. But I still get back to the easiest explanation is typically the correct explanation, which takes us back to zoonosis, or crossing from making that interspecies hurdle, moving from a bat to a human, which would not be unusual. One last thing that should give us all a little bit of fear is, so there's something called zombie viruses, which is as the planet warms and certain parts of the ice caps continue to melt away, just understand there may be viruses that have been, in essence, locked away or frozen in that ice for literally thousands of years, that humans as we know today have never seen that type of virus. A group of researchers found and identified a couple of viruses that they were able to, the viruses were not dead, they were just dormant basically. They were able to bring them back to life, which is scary in and of itself, but does remind you that the next threat of the next virus may already be out there, and is just always something that gives us concern. So as a reminder, our 4 types of communicable disease are most likely to make us sick: bacteria and virus, to a lesser extent, fungi and parasites. And to recap our words, epidemic, outbreak, endemic, and pandemic. Most things become endemic or they go away. Very few things really become a pandemic event. Each year we have outbreaks of different types of common diseases that are endemic in our communities. It's when we have a new novel virus that rapidly spreads from person to person with no known human immunity to it that we consider it a pandemic event. So this is important. What refutes science? Better science. What doesn't refute science? Your feelings, your religion, your favorite politician, your opinion after watching a couple of YouTube videos. Please understand that the scientific community will do everything they can to get it right all the time. But getting one piece of information is not always telling as getting lots of information. So science will continue to evolve as we gather more information, and we'll be able to make better decisions. But just understand that that's one of the most important things we'll get out of this is I have my faith in the scientific community because I know they're doing their best to get to the truth, and the truth is a collection of all of the facts. And the more facts you have, the closer you are to the truth. Key points today: have a plan. Hope is not a plan. Be prepared, both professionally and personally. Be prepared. What do you have? What do you need? Know when your environment is not safe, and then what can you do to improve the safety of your environment. We're not prepared for the next pandemic, but as a society, what can we do to change that? At least from your individual standpoint, what can you do to change that? And that's a wrap. If you have questions, please feel free to send me a message at this email address. Again, I'm Randy Kearns. I'm an associate professor, teach healthcare management and disaster management at the University of New Orleans. And if I can ever help you, please let me know. Thank you. Bye.